These are the companion slides to the Syndromic Craniosynostosis chapter in the 8th edition of Yeomans and Wynn's Neurological Surgery. Intraoperative considerations will include discussions of blood volume calculation and transfusion concerns. Positioning considerations include eye care and airway management planning. Planning of the incisions includes avoidance of crossing vascular territories, consideration of cosmesis, and working around shunts. Topics for complication avoidance and management include sinus bleeding, air embolism, retraction injury, and dural tears. Lastly, we will discuss postoperative issues. We find it helpful to review the circulating blood volume prior to incision. The calculation varies by age, with a preterm infant at 100 mL per kilogram, a full-term neonate at 90 mL per kilogram, a child less than 1 year at 80 mL per kilogram, ages 1 to 12 years at 75 mL per kilogram, and those greater than 12 years at 70 mL per kilogram. Since we usually operate somewhere after 3 months of age, we find it useful to remember the 80 mL per kilogram calculation, and we mention this in our timeout. We offer the option of directed donor blood for patients and find that many parents wish to pursue this. Concerns with transfusion include risk of hyperkalemia, and this is mitigated by use of either washed, packed red blood cells or ultra-fresh units. Hypocalcemia can be a concern with large volume transfusion. Our anesthesiologists monitor this throughout the case. Administering calcium gluconate is needed when the ionized calcium is less than 1. It is important to consider that a sudden alteration in blood pressure without other explanation may be attributable to low calcium. Techniques to minimize blood loss have historically included use of cell savers, preoperative erythropoietin, reinfusion of cells, and prophylactic administration of fresh frozen plasma. More recently, administration of antifibrinolytics, such as tranexamic acid, has reduced blood loss in these patients. Additional adjuncts include use of tumescent infiltration of steroid, local anesthetic, and epinephrine to lessen scalp bleeding on incision. Numerous publications and protocols exist regarding use of antifibrinolytics. We use a 10 mg per kilogram load of tranexamic acid followed by a 5 mg per kilogram infusion throughout the case. We also use a solution of steroid and epinephrine, which is infiltrated into the galea prior to incision, and have found it useful in decreasing scalp bleeding and postoperative swelling. Positioning is an important part of operative planning. Most frontal orbital advancements are performed in a supine position, while distractions and posterior vaults are often performed prone. The seal position allows access to both the anterior and posterior skull sutures. The supine position is illustrated in Figure A, prone in Figure B, and the seal position in Figure C. This is an intraoperative photo of a total cranial vault remodeling in the seal position. Careful attention to the airway during positioning is imperative, as is secure taping of the endotracheal tube. Note the large expansion on the intraoperative photo and the brain expansion on the head CT several days later, showing the brain filling the space acquired during the reconstruction. Great care needs to be taken to avoid ocular injury when positioning. This patient had exhibited severe exorbitism and required a tarsorrhaphy, a frontal orbital advancement, a mid-face advancement via a monoblock, as well as additional surgery with grafting to create eyelids to provide orbital coverage. We have found a simple hand mirror a valuable adjunct in checking positioning and making sure the orbits are free from pressure when using the horseshoe headrest. We also like a layer of 1-inch foam, which allows us to further elevate the face and tear out small areas of the foam under the eyes to keep them free from pressure. The anesthesiologist can use the mirror under the table to check this positioning throughout the case. This slide illustrates the importance of staying posterior initially with the bicoronal incision. This preserves the superficial temporal artery takeoff. This particular patient is quite brachycephalic and has previously undergone a posterior vault distraction. Note the markings outlining shunt placement. Syndromic patients may also have cervical spine anomalies, such as fused or abnormal vertebral configuration, which should be considered prior to intubation and positioning. Similarly, a tight Chiari can pose challenges as well. Positioning can impact the endotracheal tube placement. The prone patient who is flexed tends to have the endotracheal tube descend, resulting in main stem positioning and ventilation of only one lung. Conversely, In the seal or modified prone position, the endotracheal tube can ride up and damage the vocal cords or result in extubation. It is important to check breath sounds at the end of positioning prior to draping to ensure that problems do not exist. Incision planning is important, as many times these patients may require multiple surgeries with the need to access both the anterior and posterior vault. Typically, a bicoronal incision behind the hairline in either a zigzag or curved fashion is employed. This is generally more cosmetically favorable than a straight incision, as the hair falls better to cover the scar with the zigzag or curves. It is important to always take the incision posterior first to avoid the superficial temporal artery takeoff, which is outlined via dotted lines in this photo. Shunts can pose a challenge. Here you see a frontal incision has been incorporated into a curvilinear bicoronal incision to maintain good coverage of the shunt components while not sacrificing vascular supply to the scalp. Shunts also pose intraoperative challenges. We have found it helpful to leave a vascular layer of pericranium over the shunt, both to keep it in place and to hopefully help mitigate infectious risk. If the bone under the shunt must be moved, it can be advantageous to leave a circular piece of bone under the shunt and reconstruct around it. It is also important to recognize that you may be crossing large areas with no underlying bone and to consider this as you make your incision. Altered venous drainage can pose a significant risk as well. This patient had significant venous drainage through the scalp and an absent left transverse sinus. We employed the use of intraoperative ultrasound to identify these veins preoperatively and planned our incision for the frontal orbital advancement to exclude them. In these films, you can see robust extracranial drainage at the subocciput and top of the cervical spine, which have not allowed us to address this child's Chiari malformation operatively. Transosseous drainage can limit the surgeon's ability to extend the craniotomy posteriorly. A preoperative CT or MR venogram is important in operative planning. This child had multiple congenital anomalies and no normal venous sinuses, with all venous drainage occurring via the scalp. This situation was deemed inoperable. A significant pre- and intraoperative planning concern is that of providing adequate bony coverage. The young infant usually does well with making new bone, but in older patients, adjuncts may be necessary. Options include split-thickness calvarial grafts, donor bone such as rib, use of bone cement or methyl methacrylate, mesh implants, PEEK implants, or particulate autologous cranioplasty. The article cited on the slide by Zanotti and others is an excellent review of this topic and the relative advantages and disadvantages of each construct. We have found the use of autologous cranioplasty particularly helpful. The inner cortex of the bone is scraped to harvest bone chips, which can be held in place with fibrin glue. It is important to not be too aggressive in harvesting bone, as this may result in bone loss from the donor bone site. Avoiding complications is the primary goal. However, knowledge of how to manage situations such as sinus injury, air embolism, retraction injury, and dural tears is important. Sinus bleeding is a true emergency. Typically, one applies a patty or cottonoid and finger pressure while alerting the room and marshaling together help, blood, and other appropriate adjuncts. In theory, one can usually sacrifice the anterior one-third of the superior sagittal sinus. However, typically we strive to avoid opening the dura in these types of surgeries. Our preferred method is to cover the sinus with a cottonoid and pressure to temporize, and then place a U-stitch on either side of the sinus while sliding a piece of gel foam under this and removing the cottonoid. The suture is tied over this. This effectively tamponades the bleeding while maintaining sinus flow. This is particularly important over more posterior areas of the superior sagittal sinus or the transverse sinuses, which cannot be sacrificed. This figure illustrates temporary closure of the venous sinus by pressure tamponade. The dura is opened and turned over the sinus, which has been covered with a cottonoid or gel foam. Again, this is usually a temporizing measure. Air embolism is another potential intraoperative complication. We use a precordial Doppler to monitor for this and always place a wet sponge over the sinus immediately after bone removal while addressing any dural bleeding points. Excellent venous access is always mandated in these surgeries. In an emergency, one should flood the field with irrigation, cover with a wet sponge, and lower the head of the bed while communicating with the anesthesiologist, who may be concomitantly noting symptoms such as turbulent flow on the Doppler, hypotension, decreased oxygen saturations, or a fall in end-tidal CO2. It is important to be careful with retraction and place the blades flat to the brain and not on edge to avoid retraction injury. This is especially important in young infants with soft brains. Here you see an example of retraction injury in the left frontal area following a surgery for left coronal synostosis. Dural tears should be repaired. This is particularly important with cranial vault distractions, as CSF could continue to leak out of the distractor exit sites, causing serious infectious risks such as osteomyelitis, cerebritis, and meningitis. We check hemoglobin and hematocrit immediately postoperatively and again on postoperative day 1. Wound healing can be an issue, particularly if incisions are closed under stress. In that case, we prefer non-absorbable sutures such as Prolene or nylon. Infection is always a concern, and a patient with wound drainage or fevers should be worked up promptly. New deformity and/or redevelopment of an old deformity is usually an issue that arises years later and is addressed in clinic during longitudinal follow-up of these patients. Bioabsorbable plates, when exposed, such as in the photo, should be removed. These plates may also fracture. This slide illustrates what appears to be an infectious skin reaction in a patient who actually has a broken bioabsorbable plate. Treatment is removal of the plate with appropriate culturing of the wound and treatment with antibiotics if infection is found. This particular photo shows a patient who simply had a broken plate and not an infection.